And another condition, lumbar HFBD, occurs in 1% population per year. In 9% group, we conduct treatment. 2% patients are indicated for operation. And MRI revere HFBD in 1% asymptomatic patients with age over 60. There are several types of HFBD. So you can see this is septic type, there's the paracentric type, pyramidal type, and lateral type, and migration type. This combination, the definition is like this. This protrusion or contained chronic disc is not larger than 4 millimeters and not compromising more than 1/4 of central spinal canal, demonstrated on MRI. So what is the theoretical background for allergies? We use plasma to remove mucus pulses. And as you know, human tissue is composed of carbon, hydrogen, oxygen, nitrogen components. And decomposed tissue by plasma is changed to gas and result in this decompression. High energy plasma causes tissue degradation near electric shape. Energy is depleted by itself and gets electric stability. Therefore, no more tissue damage occurs. So tissue is changed to gas and is removed easily. And tissue more than 2 millimeters away get no injury at all. So it is very safe. So we use this technique to the two conditions, polypopsis, the both protrusion or explosion, and also to this candidate, which is the IDD. So this is the instrument for LDIS. And we use 3 modes for this technique. The bleaching mode is the plasma generation mode, and this is used to remove polypopsis. And we also use stimulus mode to stimulate sensory motor nerves to prevent unwanted nerve damage. And cognitive mode is used to eliminate nerves with sport discogenic pain. So this is the procedure. We have to determine the puncture site first, and after that we inject needle. So needle here is injected straight in L fibers, usually 1/3 to 1/4 posteriorly on the CM control. And we remove by needle, but we have to remove from catheter holding hand. The schist should be remain. And we inject LDIS and slowly on the CM control. And into direction is with a slow and capital advancement to lesion by making tracks. And we remove the toxins with ablation in low level. And after ablation, we draw out LDIS after stimulation and repeat same kind of procedure 10 to 15 times. And for the procedure, we remove LDIS and keep patient back for after procedures. So what are the differences with our tactics? IVIT is electronic treatment, and nucleoplasty is the ablation procedures, and decompression we can remove mechanically some part of the body material. But LDIS, the first characteristic is electrocative direction control is possible. So usually the patient who has a problem in disc, they have pathology in posterior part of the disc. But with nucleoplasty or decompression, you cannot go to the posterior part because the needle is straight. So you can go to the central part of the disc. So central compression is possible with those techniques, but it is not possible to remove the posterior part of the disc material in the posterior part of the disc. So this is the most used method of these procedures. And also safe removal of mucus pulses by plasma is possible with ablation region control. And we can save the animals and remove them selectively. And we use nubstimulate for safety. So here we see the nucleoplasty here. You use the straight needle, so you can remove the posterior part of the. You can approach to the posterior part of the disc. We use one, but controllability is not that good. So it's not a good procedure. I think most of this technique do not have any merit. So we use L-disc. We use day form. So select this decompression is possible, and we can coagulate nociceptors when the animal's fibers receive the damage, and we use oxygenation for safety. So here's the case for these procedures. Female, 52 years old, developed low back pain with right pain from 6 years ago, and usual LSK was 6, and MRI showed spinal stenosis, L3, 4, and there were multiple degenerative discs. So we performed histology, and positive control pain co-location was occurred in L3 and L4, and post-histology CT showed grade 5 red tear at 5 times. So we performed L-disc to the L3, 4 disc, and vastus decreased to the 3, 4 at second 100 days. And I'll show you a short movie for this. So this is for the honeymoon Parkinson's patient. So here, occurs of intrusion or extrusion disc. So it has nerve root. So totally located here. So we have to go to this side, but, with the compressor or lithoplasty, you cannot go to the posterior part of this. So we insert the introducer, and again, this is L-disc. So we can control, we can steer the direction from the dead gauge to 1 to the posterior side where the pathology exists. So we can use plasma to get rid of the uneated or uneated mucous boxes, then pathology improves. And we can use this procedure to treat a patient with extended pain. There's the internal disc drainage who has axial back pain. So, as you can see, if the you receive damage, then the ingrowing of the your tissue to the inner layer of the aerosol occurs. So we advance the plastic one into the damaged area, and we can coagulate the nociceptors with this instrument. Then we improve the pathology. It's very safe and effective treatment. So, okay, you can see the tip of the L-disc, and you can move it, and plasma is formed, and we can remove the uneated mucous boxes. Okay. So pain relief in classic dynamics to 0. There was no complication, no side effect at all. I'm going to skip this. Second topic is the pure neuroplasty. So in case for this procedure include field-based syndrome, spinal stenosis, spinal pain with radiculopathy due to ocular adhesion. So this is one indication field-based syndrome, and here you see is spinal stenosis. We have to, know the mechanical pain and location by spinal stenosis. So this is a normal patient, and this patient has one level central spinal stenosis. So this kind of patient has no system side at all. But if the patient has double level spinal stenosis, then the symptom develops, or one level spinal stenosis, central spinal stenosis, and also one peripheral stenosis, then the patient symptom develops. So decompression of one level stenosis can improve collocation because that level of spinal stenosis cause pain and collocation. Therefore, decompression central and foramen stems by balloon results in decreased pain for the patient. This is the principle of this procedure. Some indications require back pain and velocity due to epidural adhesions. So mechanical pain induced by perineural and epidural adhesion is as follows: chronic mechanical irritation and tactic reaction, post-perineural and urogenic inflammation, which results in adhesion and postoperative fiber tissue. As a result, blood supply decreases and nutrition deficits occurs, it's increased pain, and breakdown of blood barrier occurs, edema, reduction of urethral mobility, demyelination, and ectopic neurotransmission occurs. So perineural adhesion usually decreases urethral mobility, which interferes with CSF-mediated nutrition, resulting in hypersensitivity to nerve root, and may initiate vascular hypoxia due to compromise of the vascular supply to the nerve root. So as you can see in this left dissection of the chronic lower back patient, we elevate the ventricula with silk sutures that were subjected to 60-gram traction, and it shows L4-5 ventral epidural adhesion around here. And ventral epidural adhesion occurs more frequently at L4-5 and L5 as well. So this is balloon epidural neuroplastic kit. And here is the port for injecting contrast medium to inflate balloon. So we are trying to widen the area of central spiral stenosis or foraminal spiral stenosis with this balloon. So this balloon epidural neuroplastic catheter has excellent steerability, and adhesionalized balloon inflation is possible in the area of adhesional stenosis. And also it has fast motion locking switch to prevent movement during inflation and deflation of the balloon, and has insertion port for epidural catheter. To insert epidural catheter plus relays for neuroplasty, and it is simple and convenient method to introduce needle without plastic shears. So here is the procedures. We advance the needle introducer, and then we advance the catheter, and we perform the quarter epidural first. In this patient, you can see we cannot visualize bilateral alpha that has with the root. Therefore, we advance the catheter to the L5 area right side first, and on the way, if you feel some obliteration of the pathway, then we inflate the balloon. And again, we advance the catheter again, and at the foramen area, there was an obliteration, the blockade of the catheter. Therefore, we inflate the balloon again. And we inject pumps medium, and we can see the L5 and SM node root here. For SM node root, we have to advance the catheter like this, and inflate the balloon, and inject pumps medium. And we can move to the left side, L5, and SM. So this is a very, I think, more effective technique per neural about tissue possibly dystactic, and the elevation of stenotic intervertebral foramen is also possible to, it can reduce venous congestion, weaken irritation and compression, and also decrease perineural and urogenic inflammation. Effective drug delivery to target is possible with this technique to improve drug effect in the region, and adding chemical adhesionalized post-release at procedure like REX, decompressive neuroplasty, shows a synergistic combined chemical and mechanical adhesionalized procedures. Okay, I will see this. So this is a three-dimensional reconstruction of the dural space after balloon procedures. As you can see, there is a significant damage widening of the anterior space after this procedure. So here you see the advanced catheter and balloon dilation inflation in the target area. Complication, pain discomfort during 2 to 4 days because of the nerve root irritation during the injection, balloon catheter, and transient hyperemia or edema in nerve root due to balloon compression injury. So this is very safe procedures because it is considered safe if balloon inflation lasts less than 2 hours, but we inflate balloon only 5 seconds in this procedure. So 5-second inflation in this balloon to complete neuroplasty is very safe, but it is better to reduce inflation to room and or inflation time to the patient who complains discomfort during the procedures for safety. Okay, the last topic is the selective dural-lasis anticutaneous foraminotomy with foraminal ligament resection. So there was a lot of articles for the role of dural neurolysis, and as you can see, this is more effective and superior to a pure steroid injection. So this is how physiology I add mechanical factors such as discardation, set osteopathy, or spinal and foraminal stenosis. And by mechanical factor includes common mechanical substances. So pro-influence cytokine or TNF is very important, causing pain in this patient. Therefore, we have to get rid of the inflammatory process to treat the patient pain and symptom and sign. So, if the patient has an inflammation of adhesive fibrosis in the intervertebral foramen, pain and nerve dysfunction occurs. So we have to target at the point to the intervertebral foramen to remove this kind of phenomenon. So we perform mechanical neurology to the patient. So we use hypoxaline, hyaluronidase, steroid, and propionate. And we, in the future, we are going to use TNF inhibitor. So the problem with this in the foramen, therefore, we have to, if we want to widen the foramen, we have to remove the only thing we can remove is the ligament, not the root. So we can remove the ligament. So what kind of ligament we can remove? If you can see the ligament of the axis shown in the vertebral foramen. So internal ligament, transforaminal ligament, and external ligament. So you can see the anatomic property in the vertebral foramen, and here you can see the nerve root here, with those are root ganglion. This is not a safe area, you should not touch it. So the only area you can go safely is posterior side of the vertebral foramen, and there's a lot of ligament here. So we can remove this part, the ligament of the vertebral foramen. So external ligament, such as superior corporal trapezius ligament and inferior corporal trapezius ligament, is very important structure to be removed. For L5 area, we have lumbosacral ligament, lumbosacral foot, and L5 corporal trapezius ligament, and also minor accessory ligament. So this is the cadet dissection, and this slide shows the horizontal mid-transforaminal ligament, and also here you can see the horizontal and oblique inferior transforaminal ligament also at L1 to L4 level, but L5 level is different. So this is for L1 to L4 level again, and you can see the inferior corporal trapezius ligament, and here you can see the superior corporal trapezius ligament. So we have to remove these two ligaments, and there is also oblique inferior transforaminal ligament, as you can see here. And also at L5 level, there is the lumbosacral ligament, and also lumbosacral foot. The foot is located here. This is lumbosacral ligament, and also there is L5 corporal trapezius ligament. have to remove this kind of ligament. So you can see the lumbosacral ligament, and pull here, lumbosacral ligament here, and corpus trapezius ligament. So this is quick drawing of the ligaments of the external aspect into the anterior foramen. So here you can see this is posterior part, and this is the interior part, and this is the superior and inferior corpus trapezius ligament here. And spinal artery is located here. So if you go to the front side, it is very dangerous, but we always approach to the posterior side of the foramen, therefore it is very safe. And the nerve root is located here, so we don't have to touch the nerve root. So this is the various types of ligament in the foramen, and as you can see, there is an oblique inferior transforamen ligament here, and this is the anterior infraforamen ligament here, and oblique superior transforamen ligament here, and this is the mid transforamen ligament, and here you can see the superior and inferior corpus trapezius ligament, very important ligament structures, and this is for alpha and corpus trapezius ligament is located here. So we can cut this ligament from here, or from here and here. So role of the foramen ligament in the abdominal back pain includes inflammatory aspect. It can activate wide non-dependent nerve endings, and it can release pro-inflammatory cytokines, and vasodilation of edema can occur, and acute fibrosis occurs. In mechanical aspect, it shows periventricular fibrosis, also malposition particularly due to applied reduction intervertebral disc-pipe, cause several problems, and obstruction of foramen ligament can occur. Normally, it's a trunk of joint nerve root can occur, and intramucosal root ganglion occurs. So, this technique for percutaneous extraforaminal with the transforaminal ligament resection. The target ligament for L1 to alpha area is inferior. Inferior and superior corpus trapezius ligament and present on mid transforaminal ligament. L5 area, lumbosacral root, and corpus trapezius ligament. So this is the instrument for this procedure. This is a guide wire, and this is a trocar, and this is drill, and this is curate. So look at the end of the drill and also curate. So you can remove the ligament with this instrument. So we advance the guide to this rear, and we advance trocar and remove guide wire, and after that we advance the drill to this area. We should be advance the drill just close to the bone, and after that we remove the drill and we advance the curate, and we remove the ligament which attached to the posterior side of the intervertebral foramen. So that is the best way to widen the foramen. So you can see the spontaneous regression rupture disc after this procedure. Recently, I performed 2 cases of this technique to 2 patients who has recently a ruptured disc, and 2 patients did not receive any kind of operation, and the patient's symptom improved. So it was fantastic. So there are multiple cases. You can use this procedure to the ruptured disc patient, and at the same time, you can use this technique to any kind of patient who develops sciatica, so radiculopathy, because of the disc or stenosis at the same time. You can use this technique. This technique is developed by a neurosurgeon, so they use curate or a drill to the patient. But for anesthesiologists, it is not safe, easy to do the procedure. But after I learned this procedure, procedure, I found that this is very safe procedure, so you don't have to worry about it. So I already performed like 50 cases at the pain center, and about 80% of patients improved without any problem. The patient with the spinal instability, the result is not good. But most patients got improved at these procedures. So this is hypothesis related to increased quantity regression throughout the disc after this procedure. So draining by the material is very important. The improvement of blood supply over. So when you touch the patient, low leg, then you can feel the warmness after this procedure. Definitely. And also there is changes in the helps induced by immune response. Pharmacological inhibition of specific molecule is also possible. So this is trend in treating this disease. No operation. We have performed medical anti-inflammatory treatment to that degree. And you should not do operation of hydroelectric catheter and ligament resection to test extraforaminal vein is enough. No operation is needed. Okay, thank you very much.